Assalamu alaikum. Today I am going to discuss a case of a post-trap phacoemulsification I did. This is a young male, 32 years old. The bleb seems to be fibrosed, but still I am careful in placement of my main incision because I do not want to damage the area of the bleb, so I make the main incision temporarily. I am sitting on the head end. I make a 3-step incision. The cataract is the posterior subcapsular cataract. Make 2 small side ports and I proceed with the capsular axis. I am thinking of making a 5 to 5.5 millimeter capsular axis so that it is easy for me to manage this soft nucleus. This nucleus has little density, as you will see later on in this video. I proceed with the capsular axis and here I am done. Now in retrospect, I would have liked to make a larger capsular axis, a little larger temporally. However, it seems alright. Proceed to do hydrodissection. As you can see, a wave of fluid passing, and I continue to tap the nucleus to prevent fluid buildup behind the nucleus. The nucleus is not spinning, and here it starts to spin. As you can see, the consistency of the nucleus is soft and a little gummy, and I think it will be difficult to chop it. I coat the central endothelium with viscoelastic and I proceed to do a direct chop technique. Bury my phaco tip in the substance of the nucleus, and here I try to chop it, but it just doesn't propagate. So I do not give up hope and I decide to chop at another thicker section of the nucleus. Try to bury my phaco tip, however it just eats away at the nucleus. Bury my tip again and again, and still nucleus refuses to chop. Now I'm aware of a central bowl formation. However, I decide to make a bowl in the center so that it will be easy for the nucleus to tilt. With that in mind, I start to chip away at the central core of the nucleus, gently scraping away the thicker mass in the center, and at this point I am successful in partially chopping the nucleus, and I quickly take the dialer behind the nucleus and I am able to pull out one of the heminucleus out of the capsular bag. I'm checking if the bleb has reopened, is starting to form because of the fluid movement through the eye. Now I've created space and I'm reluctant to go into the periphery again, so I make use of the Sinskey hook to hold and bring the pieces to the phaco tip. The vacuum in this case was 500 millimeter mercury, aspiration flow rate was 40 and power was 60. with one heminucleus remaining, I try to hold it and bring it out of the bag. However, it is much larger and I have to chip away, and here it tilts and I am successful. And now as you can see a beautiful red reflex. And one of the mistakes I made during this part was, as you can see, the side port is tighter than I would have liked, and this is pushing the eye in the opposite direction when I try to reach for the cortical sheets in that direction. Because the side port is so tight, it is pushing on the eyeball in downwards. And as you saw previously, I flushed the cortical sheets which were not being aspirated. This is hydroimplantation of the lens, a single piece foldable lens which is gently pushed in the capsular bag. Now, because the patient was young, and this is actually the part of the surgery that I want you to pay most attention to, I decided to aggressively polish the entire capsule, because I did not want this male to come to the OPD with a posterior capsular pacification. So I use a Sinskey hook, the blunt tip of a Sinskey hook, to start polishing the capsule. I'm very careful here, but now when I'm polishing the under surface of the anterior capsule, I start to become more aggressive. Maybe it was a slight degree of overconfidence while polishing, and here I've accidentally torn a little bit a part of the anterior capsule, and fortunately nothing wrong has happened. So I decide to fill up the anterior chamber with air, hydrate the main wounds, and close the case. The patient did very well. Thank you so much for watching. Please comment and subscribe. Jazakallah.